Hello, I'm Dr. Indi Khosla. I'm a pediatric pulmonologist and a consultant pediatrician attached to Valsad CC Hospital for Children in Mumbai. Today I'm going to speak to you about gastroesophageal reflux disease. This is a condition which is not very uncommon, but unfortunately it's missed more often than not. Many a times you will get a smaller child, an infant, especially below the age of 6 months, who might present to you with excessive irritability. Parents may have noticed that this child is arching the back, which is also called the Sandifer syndrome. And also you might find that this child, the parents might complain, is regurgitating, ruminating, and sometimes actually vomiting. So the reason why this condition is missed is because the symptoms may not be very obvious. You may be lucky that if you find a child who is actually vomiting and you would suspect a gastroesophageal reflux disease. Many of these children also tend to have failure to thrive because they do not digest the food, the milk that they are consuming, and they tend to vomit very often, and therefore they may have failure to thrive. When you have a child who is vomiting early in infancy, and some of them may actually choke, so they may vomit, and the milk or what they've consumed may go into their airway, causing them to have an acute life-threatening episode. So these are the ways where children can manifest. Now, occasionally, children may also manifest with recurrent cough and wheeze. So some of this, what they vomit may get aspirated into the airways. You may have microaspirations causing wheeze. And you may have macroaspirations, especially if a child is mentally retarded, causing pneumonias. So you need to think of a gastroesophageal reflux disease if you have a baby who's irritable, who's failing to grow, who tends to vomit or ruminate or regurgitate, with or without respiratory tract symptoms. Now, you also need to think of a differential if you have a child with vomiting. So it's not uncommon in our country nowadays to find cow's milk protein allergy which just presents with vomiting. You need to think of metabolic disorders, certain renal disorders which may make the child present to you with vomiting. When you have suspected a gastroesophageal reflux disease, you need to do some specific investigations to find out the cause. Unfortunately, we really don't have a gold standard single test to diagnose gastroesophageal reflux disease. So you may do a technetium scan or a milk scan, but again here you may get a lot of false positives. Some people do barium studies, but barium studies is good for anatomical defects, and you may pick up only a reflux if it is happening at that point of time. And it's not easy to identify a reflux doing a barium meal. 24-hour pH monitoring, the good point is it gives you an association. So if the child has had a reflux at that time and has had a cough or has had a vomit, you can actually associate the two conditions and therefore prove that there was a reflux. The negative is it's not available everywhere, and also it only picks up acid reflux because the probe is lying in the lower end of the esophagus, and it picks up only the acid reflux where the pH goes down below 5. There is also another investigation called as multi-channel impedance manometry. Again, it has its good points and negative points, and the unfortunate part is not freely available. So how do you manage such children where you suspect gastroesophageal reflux disease? So what is recommended is a therapeutic trial. Okay, so there is management, if I were to say correctly, are twofold. There are non-pharmacological methods and pharmacological methods of management. The non-pharmacological methods include thickening of feeds, keeping the child upright to reduce the reflux. Okay, and these definitely help, and there are large studies to show a good 25% of children just responded to thickening of feeds and upright posture. Some of the kids are actually overfed and therefore they regurgitate a lot. So giving the correct volume of feed also definitely helps in some of these patients where you're suspecting gastroesophageal reflux disease. Also, those who do not respond to this, they are not a simple GER, that is gastroesophageal reflux, but they are actually gastroesophageal reflux disease. These children will require some pharmacological interventions. And what is required is to reduce the acid reflux which is coming from the stomach and going up and causing all the symptoms of heartburn and irritability, etc. And only in very, very severe cases you may need a surgical intervention like a fundoplication. So this is how one would manage a gastroesophageal reflux disease. It is very important to suspect it and treat it because recurrent aspiration into the lung can cause long-term damage to the lungs, and also children who don't grow in the first year of life have poor neurological outcomes, and therefore you need to identify and need to treat these patients properly.